Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 371 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The next case reads, JAP, a 60-year-old woman, presents to the emergency department with complaints of malaise, generalized weakness, nausea, and vomiting for 3 days. Her medical history includes hypertension for 20 years. JAP's current medications include hydrochlorothiazide 25 mg per day and nifedipine XL 30 mg per day. She has not been able to take her medications in the past few days, however, because of vomiting. JAP denies recent diarrhea or use of laxatives. Her blood pressure is 130 systolic 70 diastolic with a pulse of 80 beats per minute while sitting, and 120 systolic 70 diastolic with a pulse of 95 beats per minute on standing. Physical examination reveals a thin, older woman with poor skin turgor, dry mucous membranes, and a flat jugular vein. T-wave flattening is noted on the electrocardiogram, ECG. Laboratory tests show the following. Serum sodium levels of 138 milliequivalents per liter. Potassium levels of 2.1 milliequivalents per liter. Chloride levels of 100 milliequivalents per liter. Bicarbonate of 32 milliequivalents per liter. A BUN of 30 mg per deciliter. Creatinine of 1.2 mg per deciliter. Glucose levels of 100 mg per deciliter. ABG shows a pH of 7.50. Partial pressure of carbon dioxide of 45 mm of mercury. And partial pressure of oxygen of 70 mm of mercury at room air. Urine electrolytes are sodium, 30 milliequivalents per liter, potassium, 60 milliequivalents per liter, and chloride, less than 15 milliequivalents per liter. The patient's presentation is consistent with gastroenteritis. So my question to you is, what are the causes of JAP's hyperkalemia? When evaluating hyperkalemia, the clinician should determine whether the hyperkalemia is a result of low intake, increased cellular uptake of potassium, or excessive loss of potassium via the kidneys, GI tract, or skin history and physical evidence of potassium depletion, medication history, including use of over-the-counter medicines, and assessment of the patient's blood pressure, extracellular volume, and concurrent acid-base status can provide clues to the causes of hyperkalemia. Because JAP has been unable to eat for the past few days, decreased oral intake may have contributed to her hyperkalemia. Because most foods are rich in potassium, however, inadequate intake rarely is the sole cause of potassium depletion unless inappropriate and continued renal or extrarenal losses occur, or potassium intake is severely restricted to less than 10 to 15 milliequivalents per day. Alkalosis, insulin administration, hypertonic solution administration, periodic paralysis, beta-2 agonists, barium poisoning and treatment of megaloblastic anemia with vitamin B12 all have been associated with increased cellular potassium uptake. Although the relationship between the degree of hyperkalemia and increase in blood pH varies widely, JAP's metabolic alkalosis probably enhances the cellular uptake of potassium. The transcellular shift of potassium should not result in total body potassium depletion, however. The GI tract is an important site of potassium loss, particularly through vomiting and diarrhea. Because the potassium content of gastric secretion, 5 to 10 milliequivalents per liter, is much less than that of the intestinal secretion, up to 90 milliequivalents per liter, loss of a large volume of gastric secretion is needed to produce substantial potassium depletion. Potassium deficit induced by vomiting, however, is commonly secondary to renal potassium loss, especially within the initial 24 to 48 hours. The loss of hydrogen ion in gastric juice results in an elevated plasma bicarbonate concentration. The increased amount of bicarbonate ion, as a non-resorbable anion, increases water delivery to the distal nephron and enhances sodium reabsorption and potassium secretion, resulting in hyperkalemia. The potassium wasting is often transient, because increased proximal reabsorption of sodium and bicarbonate will result in diminished bicarbonate delivery to the distal site. Reduced potassium excretion will ensue, commonly within 48 to 72 hours. Subsequent potassium loss will then be primarily consequent to gastric secretion removal. The absence of diarrhea in JAP excludes the GI tract as the source of potassium loss. Potassium loss through the skin is also unlikely in JAP because the potassium concentration of sweat is less than 10 milliequivalents per liter. Therefore, profuse sweating, such as that induced by vigorous exercise in a hot, humid environment, or severe burns are needed to cause substantial loss. JAP's inappropriately high urinary potassium concentration indicates that the kidney is the source of the potassium loss. The urinary potassium concentration is a good marker for differentiating various hyperkalemic syndromes. A urinary potassium excretion of less than 20 milliequivalents per day suggests extrarenal potassium loss. Renal potassium wastage cannot be excluded, however, unless the low urinary potassium excretion is accompanied by a sodium intake of at least 100 milliequivalents per day, because a low sodium diet can reduce renal potassium excretion. In JAP, the metabolic alkalosis and hypovolemia promote renal potassium wastage. The distal delivery of a large sodium bicarbonate load and increased aldosterone activity, from hypovolemia, enhance potassium secretion and severely impair the kidney's ability to conserve potassium. The hydrochlorothiazide, which JAP had been taking until 3 days before admission, could also have induced hyperkalemia through volume depletion, hypochloremic metabolic alkalosis, and renal potassium wastage. The diuretic is unlikely, however, to be the cause for JAP's hyperkalemia because she has stopped taking the medication, and this is reflected by the low urinary chloride concentration. Bartter syndrome, which presents as normotension, hyperkalemia, hypochloremic metabolic alkalosis, and renal potassium wastage, is characterized by impaired renal sodium and chloride reabsorption. The low urinary chloride concentration in JAP can rule out Bartter syndrome. In an asymptomatic hyperkalemic patient with no apparent causes for potassium depletion or transcellular redistribution, pseudo-hyperkalemia should be excluded before pursuing an intensive evaluation. Spurious hyperkalemia can occur in leukemic patients whose leukocyte count ranges from 100,000 to 250,000 cells per microliter. The potassium in serum is taken up by the large number of leukemic cells when the blood specimen is allowed to stand at room temperature. The next question reads, what clinical manifestations of hyperkalemia are evident in JAP? The clinical presentation of hyperkalemia, which depends on the severity of potassium depletion, is a result of changes in cell membrane polarization. Patients are usually asymptomatic when the plasma potassium level is 3.0 to 3.5 milliequivalents per liter, but they may complain of malaise, weakness, fatigue, and myalgia. JAP's muscle weakness and ECG changes reflect the muscular and cardiac manifestations of hyperkalemia, respectively. Potassium depletion can lead to hyperpolarization of myocardial cells and a prolonged refractory period. When serum potassium concentrations fall below 3 milliequivalents per liter, T-wave flattening, straight tubule segment depression, and prominent U-waves are seen on the ECG. Mild hyperkalemia, potassium concentration of 3.0 to 3.5 milliequivalents per liter, is potentially arrhythmogenic in patients with underlying coronary artery disease. The incidence of ventricular arrhythmia increases with the degree of hyperkalemia. Patients without underlying heart disease may be susceptible to these myocardial effects during exercise, especially if the patient's pre-exercise potassium concentration is less than 3.5 milliequivalents per liter, because the potassium concentration may drop to less than 3.0 milliequivalents per liter as a result of beta-2 adrenergic receptor-mediated cellular potassium uptake. Potassium depletion may also increase the blood pressure, which can be lowered with potassium supplementation. When the serum potassium concentration is less than 2.5 to 3 milliequivalents per liter, muscle weakness, cramps, general malaise, fatigue, restless leg syndrome, and paresthesia can occur, probably because potassium is necessary for vasodilation in skeletal muscle. In addition, severe potassium depletion, that is less than 2.5 milliequivalents per liter, can result in elevation of serum creatine phosphokinase, aldolase, and aspartate aminotransferase levels. Rhabdomyolysis can ensue when the serum potassium concentration falls below 2 milliequivalents per liter. Chronic potassium depletion can alter renal function and structure, which can manifest as decreased glomerular filtration rate and renal blood flow, disturbance in tubular sodium handling, impaired urinary concentrating ability with polydipsia, and antidiuretic hormone-resistant nephrogenic diabetes insipidus. Reversible pathologic changes include renal hypertrophy and epithelial vacuolization of the proximal convoluted tubule. Interstitial scarring and tubular atrophy have been reported with prolonged potassium depletion. Other effects of hyperkalemia and potassium depletion include decreased insulin secretion resulting in carbohydrate intolerance, metabolic alkalosis, and increased renal ammoniagenesis, which may play a role in the development of hepatic encephalopathy. The next question reads, how should JAP's hyperkalemia be treated? JAP's protracted vomiting should be corrected, and fluids and electrolytes, sodium, potassium, and chloride, should be replaced to correct the volume deficit, hyperkalemia, and hypochloremic metabolic alkalosis. Hydrochlorothiazide should continue to be withheld. The amount of potassium deficit and the rate of continued potassium loss should be determined to guide replacement therapy. It has been estimated that a 1 milliequivalent per liter fall in serum potassium from 4 to 3 milliequivalents per liter represents a total body deficit of approximately 200 milliequivalents. When the serum potassium falls to less than 3 milliequivalents per liter, the total body deficit increases by 200 to 400 milliequivalents for each 1 milliequivalent per liter reduction in serum concentration. Other data suggest that even greater degrees of potassium loss can occur. A deficit of 100 milliequivalents per 0.27 milliequivalent per liter fall in the serum potassium concentration. Transcellular redistribution of potassium may, however, significantly alter the relationship between serum concentration and total body deficit. Therefore, potassium repletion should be guided by close monitoring of serum concentrations and analysis of JAP's urine for potassium content to help assess the need for additional replacement. The route of potassium administration depends on the acuity and severity of hyperkalemia, but oral supplementation is usually preferred. The parenteral route is indicated for patients who cannot tolerate high dosages of oral potassium supplements and for those with severe or symptomatic hyperkalemia. JAP's potassium deficit is estimated to be 300 to 500 milliequivalents, but because she is only moderately symptomatic, aggressive therapy is not indicated. Potassium chloride can be added to her IV fluid in a concentration of 40 milliequivalents per liter and infused at a rate that does not exceed 10 milliequivalents per hour. For patients with life-threatening, hyperkalemia-induced arrhythmias or those with a serum potassium level less than 2.0 milliequivalents per liter, a more concentrated potassium solution, that is 60 milliequivalents per liter, can be infused at a rate not exceeding 40 milliequivalents per hour. A solution that is too concentrated or a rate of infusion that is too rapid would likely cause phlebitis in the peripheral veins and could cause arrhythmias, especially when administered through a central line. The potassium concentration should be monitored every 4 hours, more frequently in patients with severe potassium depletion or when a rapid infusion is given. ECG monitoring is mandatory to identify life-threatening hyperkalemia that can result from overcorrection. Parenteral potassium can be given as chloride, acetate, or phosphate. The chloride salt is preferred in JAP, who has concurrent hypochloremic metabolic alkalosis. The acetate preparation is useful in cases of concomitant metabolic acidosis. Potassium phosphate is indicated if hypophosphatemia coexists. In the latter condition, the serum calcium concentration should also be monitored because hypercalcemia may ensue. Glucose solution should be avoided as the vehicle because glucose-induced insulin secretion will promote intracellular potassium uptake. Once JAP's potassium levels are replenished and she can take medicine by mouth, oral potassium chloride can be started. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 372.